Welcome to Menopause Rescue. I'm Dr. Polly Watson. Midlife women are often caught up in a sea of symptoms. Too often, they're overwhelmed by the lack of support from mainstream healthcare. They're inundated with so-called experts who are selling solutions which may lack credibility. I'm a Menopause Society certified gynecologist with both traditional and functional medicine training. I'm here to guide you through this transition and help you decipher the facts from the fads. Armed with credible information, I hope you are empowered to rescue and restore your health, making the second half of your life your best. This is part 2 of our conversation with Dr. Felice Gersh. If you're not familiar, Dr. Gersh is a menopause expert and really a veteran in the field. She is double board certified in both gynecology and in integrative medicine. In part 2 of our conversation, we're going to be talking about the complexities with different formulations of hormone replacement therapy in terms of cycling on and off progesterone versus a continuous dose, and kind of the risk and benefits or the different treatment considerations in that decision. I hope you'll join us for this really lively conversation with Dr. Gersh. Hearing a lot about thinking about the whole body. We're not thinking about menopause as just our periods, right? We're thinking about estrogen and progesterone's effect on our heart, on our brains, on our bones, kind of the whole body. And also like maybe not waiting until someone's fully menopausal to address the problem, that like you say, this is a continuum. So this is kind of a good segue to talk a little bit about types of hormone administration. So for maybe audience members who aren't familiar, we can give hormone replacement therapy 2 different ways. We can cycle the progesterone to sort of mimic a cycle that someone would have when they're still in their reproductive era. And in that kind of program, someone's typically given progesterone for about half the month versus giving the same hormone the whole time through the month. So I would love it if you could kind of share with us which way you kind of like to do it and why you like to do it that way. And then maybe I've got some follow-up questions on that because I know a lot of my patients would give me feedback on this. So let us know kind of which way you prefer and why.
Well, I'm going to take one step back and then I'm going to totally address that. And that is that there are different practitioners using different forms of estrogen, as well as how they give it, like whether it's oral or transdermal. And then also then you get into whether you give it continuous, static, or give it in a cyclic way. So estrogen is a family of hormones. It's not a hormone. Right. And the one made by the ovaries is called estradiol. The real name would be 17-beta estradiol. And like the B vitamins, it has a letter and a number. So it is big letter E, capital E, and then the number 2. There's also estrone that has a big E, number 1. And then there's estriol, that's big E, 3. And there's a fetal estrogen, which I'm not going to go into, but it's in actually birth control pills and will be in additional menopausal hormone therapies coming forward. And it is a fetal estrogen, never, ever seen in a human adult female, estetrol, and it is E4, and I see no point in using it except maybe one thing, but we'll do a talk on that when it really comes out for menopause. It's not available yet, is that it seems, based on its receptors, that it has no negative potential for breast cancer. So It may have a niche. It may have a niche, but we'll deal with that when it comes on the market. In terms of the estrogens, there are some people who are prescribing what is called bi-est, which is predominantly estriol, E3, usually in the ratio of 80% of estriol to 20% of estradiol, based on like data from many decades ago in a teensy like 9%. I'm not against estriol. That's the dominant estrogen of pregnancy. It works predominantly on one estrogen receptor called the beta receptor. Estrone works predominantly on the alpha receptor. Only estradiol has the balanced effect on all the receptors, the alpha, the beta, and the membrane receptor, and even the alpha and the beta there are subsets of them. We know everything's more complicated than we thought. And these receptors actually interact with one another. If you have a lot of beta, it actually downregulates alpha. There's a lot of interaction. And different organs have a different propensity to have more or less of one type of receptor than another. Like the bones and the muscle are more alpha. The arteries are more alpha. The heart has alpha and beta. The gut, the entire gut is more beta. In the brain, the hypothalamus is more alpha. The master clock is more beta, and the cortex is more beta. Skin tends to be more beta, the vagina more beta, but it's never one or the other exclusively. There's a mix. And then the membrane receptor is like throughout in all kinds of ways. Different functions are controlled through the membrane receptor, creating these rapid responses, kinases, peptides, and things that have rapid production and response. So you need them all. And you can't micromanage the body. I'm sorry. No one I know, including myself, is smart enough to micromanage all the estrogen receptors simultaneously in the body. That's absurd. So you give the body the basic hormone that was produced by the ovaries, and then the body will self-regulate how much of it turns into this form and how much of it turns into this form when it's going to bind to this receptor, activate, and so on. So we should not try to micromanage the body. Like the immune system, the innate immune cells, like the first responders, are alpha predominantly. The ones that produce antibodies are predominantly beta. We just have to let the body manage itself. The immune system is so amazing and complex, and we don't want to downregulate it so that you can't produce the proper response if you get infected or traumatized, So we just want to use estradiol. Now, we want to use it topically because if taken orally, it gets modified through digestion into E1 estrone when it goes into the bloodstream. So you have to take it through the skin either as a patch, a gel, or a compounded cream. And I'm anti-pellets. Maybe that's for another day because the physiology of the levels produced is just not human at all. So the testosterone pellets really drive me crazy. They get male levels for the first month. That's why most doctors who do pellets won't get any testing because they don't want to have a documented report that shows that they were doing something weird, with the levels that they're creating in the patients. So we'll just get rid of that one altogether. So now, among the many amazing benefits of estradiol is the creation and production of growth factors. Now, growth factors can create growth, like you can grow new bone and you can grow new replacement cells, right? That's why we have stem cells. That's why everyone loves stem cells, but they don't think about what the heck is happening with stem cells? Well, they are the pool of primordial types of cells that can then turn into a mature cell. So you got to have enough stem cells. Estradiol actually helps maintain stem cell pool, okay, which is really important. When you lose all your stem cells, you can't replace dead cells. Then you will be dead. So we do not want to have a bad stem cell pool. So growth factors. Now, in the brain, a growth factor is like brain-derived neurotrophic factor, which means it grows neurons. You want to have some new friendly neurons to think with, and you want to repair and rejuvenate, regenerate. Yeah, so you want to have that in your brain. Then we have like VEGF, vascular endothelial growth factor. You want to create collateral blood vessels to keep your heart perfused so that if something goes wrong, we have a lot of ancillary arteries and blood flow. You want to have an injury be repaired, like you get a laceration. You want to create new tissue. You want to create new blood flow to that tissue so it can actually thrive. You need to have these growth factors, okay? They're not evil. You need them, okay? When you have dysregulated cancer, then you get inappropriate created growth factors. That's what we want to prevent by having proper hormones, nutrients, reducing inflammation, getting rid of misfolded protein and senescent cells, so zombie cells. All of that is really under the control and modulation of estradiol. And then you won't hopefully have cancer. Women have way more cancer of every type after menopause when they lose their hormones, not before. Right. The reason younger people are getting more cancers like colon cancer, which is reduced by estradiol, okay? Right. The reason they're having more cancers is because of the crazy foods that are being fed to kids, the antibiotics, the chemicals in all of our, water supply, and so on. So it's what they don't eat, the right nutrients, the fiber. So many kids are born by C-section. Who knows what else is contributing, but they don't have the right gut microbiome from the day that they're like born even, things are all messed up. They're hardly breastfed and formula is weird. So, it's like there's so many strikes against kids now that we're getting such young aged onset of colon cancer, but it's not because they have hormones. That's not the reason. Women get breast cancer when they're younger, premenopausal, not because they have hormones, but because their hormones have been like subjugated and tricked by endocrine disruptors, chemicals and such, pesticides and other plastics and things in the environment, not because of our hormones. So the bottom line is that we need growth factors. Now, what happens in the uterus when you have enough estradiol to create all the proper controls and growth factors and everything in the body, and to maintain growing tissue and restoring, rejuvenating, apoptosis, that also is part of growing, is part of dying. It's like a cycle, right? So all of that is controlled by estradiol. The autophagy, this intracellular renewal, is controlled by estradiol, but you have to have the right amount, right? So if you're going to give the right amount to do all these wonderful things all over the body, guess what is going to happen in the uterus that has a lining? You're going to grow it. The growth factors that are doing all these things to keep all the organ systems thriving is going to cause growth of your uterine lining. So here's my motto. If you grow it, you must shed it. I mean, it's not, what is this, Jack and the Beanstalk? It grows and grows and grows until it reaches like I don't know, some far distant galaxy. It doesn't work that way. You can't just keep growing your uterine lining. Something's going to happen, like it's going to fall out. It's like a tower of blocks. You can't just grow that up and like through the roof and it just keeps going up. It's going to get like unstable and it's going to topple. Okay. So if you don't intentionally topple out and clean out that uterine lining, creating a timed bleed, you're just going to have random bleeding, which is not what any doctor or patient wants. We don't want our patients just randomly bleeding. It's like, that's, first of all, you don't even know what that bleeding is at a certain point. It's like, do you have something bad going on there? Or is it what we call dysfunctional uterine bleeding, or disordered, we call it disordered proliferative. It's proliferating and it's all weird. It's like all different heights at this point. So it gets too tall. This part falls out and bleeds. And then this part is now shorter. And then this part is now too tall. So it's all different heights, all of your uterus, and it's all crazy. So we can't have that happen. So here's the reality. If you want to have an adequate response, you have to give an adequate dose. And if you have a uterus, that's going to grow your uterine lining. If you grow it, you must shed it. And the way you shed it is by giving cyclic progesterone the way it was designed to be in your body when you're at the healthiest time of your life during the reproductive years. So like you said, it would be like 2 weeks on, approximately. I go by the month because then like it's a 30, 31 day, but it's easier than working with 28 days. So it's like 2 weeks of the month you're on progesterone and the rest of the month you're not. And then after you finish the progesterone or get close to finishing it, you will have a bleed. It's not like you're fertile again. We don't have that power if you wanted it, but it's real blood. It's a fake period, but it's real blood. Okay, because it's a fake period because you're not ovulating, but you're creating cyclic growth and shedding of the uterine lining. You can think of it though as when you shed the uterine lining, you're shedding crappy cells everywhere. Think of it as a catharsis, a purge of bad garbage in your body. Nature made it so everything is like the Chinese yin yang, right? So you sleep, you're awake. You eat, you fast. You grow, you shed. You purge.
I totally hear you. And with love in my heart, I'm 50. I'm on hormones. I've been on hormones since I was 40. Kind of had the early thing, right? I sleep so much better when I have progesterone on board. And when I don't have progesterone on board, I don't sleep well. So, like, how do you talk to your patients who say that they don't sleep well off progesterone, their mood's a little agitated, maybe they don't want to cycle? Sometimes you get a little pushback from patients.
If you don't want to bleed, you can still have enough estrogen to feel better, because we already established that. It
Right.
takes far less estrogen to feel better than to support all the organ systems optimally. So if you don't want to bleed, these are the compromises that have to be made. You have to give a smaller dose of estrogen than would be optimal, because
Right.
that's just what you have to do, but it will still help you feel better. Okay.
Mm-hmm.
And you have to give progesterone every night, which you obviously like and others have. I agree. You have to give progesterone because progesterone is a little bit like the antidote to the growth of the uterine lining. So in a normal menstrual cycle, after ovulation occurs, progesterone is produced, and progesterone suppresses the growth factors, and it turns the uterine lining from proliferative into secretory. It's kind of like a tree that's growing and then it stops growing, puts out branches and flowers and leaves, so it's like fills out. It's like the kid who grows and grows and grows, and then he stops growing and then he grows muscle, So that's like the uterine lining. It's become secretory. It like makes mucus and it's like fluffy kind of thing. Okay, so you have to give progesterone all the time to counteract the growth effects. But you have to accept the following. You're basically countering the benefits of estrogen everywhere in the body. So it's a compromise. You have to decide what your goal is. If your goal is, I just want to feel better, I want to sleep better, I just want to feel better, and I'm going to do other lifestyle things, because hormones are foundational but not sufficient to healthy longevity. You still have to eat the right foods, and you have to work on fitness and sleep and controlling stress and environmental toxicants and all those things, right? So it's like foundational, like you build a house, you put down a foundation, but you can't live on a foundation. You got to put in the walls and the roof and the plumbing and the electrical. That's all the lifestyle stuff. But if you say, you know what, I will accept the limitations, I just want to feel better, and I'll do as much of the other stuff as I possibly can and hope I have good genes, and I'm going to do, because nobody knows the future. There are people that live to 100. They never even have been on hormones. They're not a lot. Okay. Most of those who are living to that age have fractures and dementia and, other osteoarthritis. So it's a very exceptional person. It's like somebody wins the $1 billion lottery, but it's not most people. Okay. And I deal with medical probabilities, not the outliers, the 1% in a million that doesn't need any help from anything, and they just live to be a perfect 100. But, I don't count on that. So the bottom line, if you want just to feel better, which is not a just, if you want to feel better and, sleep better, and you're willing to accept that you're not getting optimal effects of these hormones, either the progesterone or the estrogen, because these hormones, estradiol and progesterone, have this also yin yang, not just with growth, but with other things as well. Progesterone downregulates testosterone receptors. It downregulates estrogen receptors. Estradiol upregulates its own receptors, thyroid receptors, testosterone receptors, and progesterone receptors. So you have this sort of on-off, like rhythm of hormone receptors going higher and lower. It's like the body is not static in any way. There's the rhythms of the hormones and the receptors. And what these also are changing is how genes are expressed. There's published data that shows that muscle is built better and functions better when progesterone is not on the scene. Like without the progesterone is the best time for muscle to function and to be optimally working. That's why they have studies showing when women are having natural cycles and they're like Olympic athletes, like what time of the cycle are they more likely to be successful? When are they less likely to have injuries and so on? Because these hormones affect the musculoskeletal system and performance as well. And there's studies like women who have PMS, what's going on? It's changing their autonomic nervous system. They often will have a downregulation of the parasympathetic and upregulation of the sympathetic, which is like the stressors. You're playing with all kinds of things that you meaning like everybody out there, they don't even understand the consequences of changing physiologic dosing into something alternative that never exists in nature. But I'm not saying it doesn't have benefit to be on static dosing of estrogen and progesterone, I do believe it has benefit. I don't believe it's optimal benefit, but I do believe it's benefit. But I have patients that are on that because they say to me, it's a deal breaker to bleed. And
Right.
I accept that. Like I have patients that say, I'll exercise 2 days a week. Well, I'd say, I'd rather you exercise 5. What am I going to do? Like hit them, like yell at them? I'm not going to yell at my patients. I'm not going to
Right.
beat them up because they
Yeah.
only exercise 2 days a week instead of the required 5, So I'll take what I can get. Better is better than nothing. I can't
Right.
expect best. They say best is, don't let best be the enemy of better. All I want is what we call in medicine informed consent, that people make an educated decision. That isn't happening in most medical practices. Women are not being told what it means to make this choice or another choice. By the way, in some women, so progesterone is also a neurosteroid. In other words, the
Right.
brain actually makes progesterone, and maybe yours doesn't make enough for whatever reason. So I will sometimes give women a very small dose of progesterone that will go all month, like say 25 milligrams, which
Mhm.
is, the idea that I'm helping them to have a little bit more in their brains as well. Sometimes giving a higher dose of estradiol will also help them because the endocannabinoid system is heavily embedded in the brain. And one of the endocannabinoids called anandamide, that's the same one that THC from cannabis binds to, is anandamide, and estradiol upregulates anandamide function and production, which is an endocannabinoid, which makes people feel calm, relaxed, and less anxious. So sometimes raising the estradiol dose actually helps people sleep better.
Sure.
So it's like, all these things are so interconnected. But
Yes.
I will give people a little bit of progesterone all month long if they feel that they need it, along with, some herbal things like people know, like ashwagandha and so on. But and then I do, like, you can rub lavender oil in the bottoms of your feet, take a hot bath, make the room really dark, take a tiny dose of melatonin, do light therapy, watch the sunset. We have to work on all these things. Sleep is elusive for a lot of people. We have to work hard on that. But I just want people to understand that by replicating as reasonably as we can, it's not precise, not even close, what is in the body from a hormonal perspective that is optimal when you're reproductive age is what I would like women to have at every age. Remember, every cell of your body is a different age. There's only a few cells in your body, like in your heart, in your brain, that are still there from the day you were born. All the other cells have died and been replaced by new cells. When a new cell is born from your stem cell pool, it doesn't know how old you are. It's just genetically programmed to do the same thing it was genetically programmed to do 20 years earlier. Like, we just have to give it what it needs, which means you need the right hormones, you need the right micronutrients, macronutrients, and you don't want to poison it. In terms of the cardiovascular system, every single organ part, every level of the artery wall, every part of the heart, the conduction system, the coronary arteries, the myocytes, the muscle cells, the mitochondria, every single component of the cardiovascular system has estrogen receptors. And not only estrogen receptors, this is like the most amazing thing. Estradiol is metabolized, and a metabolite to methoxyestradiol, which is a liver-produced metabolite of estradiol, has its own receptors in the heart to create more energy. Because the
Yes.
heart of a woman has to be more energetic than a male heart, because during pregnancy, a woman's blood volume increases at least 50%. So her heart has to pump 50% more blood around the body. So you need a really strong heart. That's why now we're actually finding women who are unhealthy, they don't have a good heart, they go into like heart failure. It's like a horrible thing. There's been acute heart stoppages in delivery rooms. It's just a horrible thing. You need a healthy heart, and the arteries that serve the blood and oxygen, the nutrients to the heart. Like I said, every aspect of vascular health is modulated, regulated by estradiol. The enzyme systems involved in vascular dilation, platelet function. Nitric oxide is produced in arteries under the influence of estradiol, the conduction system, the autonomic nervous system that controls heartbeat. That's why without enough estradiol, women have high incidence of tachyarrhythmias, like high fast heartbeat and palpitations, irregular heartbeats, atrial fibrillation, and even a rare event but can be fatal, which is Takotsubo syndrome or broken heart syndrome, which is really autonomic nervous system sympathetic overload. Women have these palpitations and they go in, the cardiologist instantly puts them on beta blockers, which is working on the autonomic nervous system, the sympathetically like activated part, when really what they need is estradiol.
I really appreciate all your time and expertise. I think I could talk to you all day, but I don't want to make you late for a clinic. And I think that ending on the strength of the female heart and the power of that is a great place to wrap up. Thank you so much for your time. This has been fantastic.
My pleasure. Thank you for giving me a platform to tell women all about these very important facts.
Thanks for listening to Menopause Rescue. We hope you've enjoyed this podcast and it helps you create some time and space to make this the best half of your life. If you've enjoyed this content, please leave us a 5-star rating and review. This helps other listeners find this resource and rescue and restore their health. If you enjoyed this topic and want to learn more, check out our resource guide for this episode. If today's podcast resonated with you and you want to take a deeper dive, check out my educational resources. We offer basic membership, which is an archive of over 100 videos on menopausal topics ranging from bone health to libido. We add to this archive every month, so the resource becomes richer and richer over time. If you're looking for a menopause expert and live in North Carolina, take our free online class and see if we're a match for your needs. It's called Are We a Good Fit? And is a quick and easy way to learn more about our practice and what it has to offer. Hey, this is Dr. Watson. This is just a friendly reminder that this podcast is for general information purposes only and does not constitute the practice of medicine. No doctor-patient relationship is formed, and any information you get from this podcast is considered educational only. You should make medical decisions with your healthcare provider. The content of this podcast is not intended to be a substitute for professional medical advice. Listeners should not disregard or delay in obtaining medical advice for any medical condition, and they should seek assistance from their healthcare professionals.